Sounds great. Well, like I said, this is more of a compilation. Every Friday morning and evening, we've had for the last 4 weeks, we've been lucky enough to have a call, an international call and a domestic call with multiple different centers across the country and world that we've talked about more or less outline the COVID strategy or how to treat these COVID patients, whether it be before ECMO, during ECMO, and even after ECMO. So that's kind of what I'm going to try to put together today as a compilation of what we've talked about. So we'll get into it. Next slide. And so the reality is that it's not a matter of if you're going to see this, it's a matter of when. We know that this strain or this virus has had multiple strains already. We've seen that with the reinfection of some people that have already been, quote, had a positive test. They're 14 days out, their viral load is completely gone, and then they get reintroduced. We've had that in the Paris experience, and we've had with Italy and Japan that we've been talking to. We've seen that. So there are, it seems like indications that there's going to be multiple strains of this. And so if, this may happen again this fall, and unfortunately may even happen up to next year with different strains of this particular coronavirus. Next slide. And so, I kind of wanted to get a little cheeky with this, but it is good to have friends in low places. And, if anything, a lot of times people, even in the medical community, so as much as we share things, there's a little bit of, your special little sauce on things. That has not been the case here. People have completely come forth, right, with anything that works for them, anything that doesn't work, and really thinking outside the box. There's been no, suppression, what I would say, of any kind of novel idea or of a strategy when thinking about this. So there's a lot of things that have been thrown at the board and say, hey, what do you think about this? There has been quite a bit of discussion, and then some people just said, well, we just probably need a small trial, and what they're looking at is putting between 6 and 12 patients in these little, what I want to call sidearm trials that they're doing. A lot of that is happening in Paris, and a lot of that is happening in Japan. And so for the most part, there's a gentleman, Jan Schmidto. He's from Hanover, Germany, and he actually did some of his medical school at the Brigham in Boston, and he's actually been over in China since February 7th. He's been at the Peking Union Medical Center College Hospital, and he's been there since February 7th. And so to play out the whole spectrum of what we've seen, he has seen it from what I want to say from the beginning, and now he's, they're almost, past, the curve. And so he's probably got the most experience with ECMO patients as far as a continuum of healthcare. He doesn't have the volume, but he does have the continuum. So this is his recommendations personally, and of the treatment. He says early intubation and the probing and proning and early ventilation and tracheostomy is actually the way to go. They see that if you don't let the lungs get so beat up, and they've almost they've called this a self-induced acute lung injury, and I've never heard of that before, but it's been talked about a lot, where it's actually it's your own inspiration and respiration trying to keep up with the body's demand of metabolic, that you're actually hurting your own lungs just by trying to keep up with it. And so what they're recommending is that early onset of intubation, sedation, and paralysis, and just trying to not let your own body beat up the lungs. He moves on and talks about, don't expect too much from the antivirals. Whether it's hydroxychloroquine and azithromycin, whether it be lopinavir. He says that the problem is that with putting these antivirals in, it doesn't really help unless you get the early administration, kind of like what we see in Tamiflu. And a lot of the times, your viral load in these patients are so low, it's undetectable, but the virus is still in the patients because upon autopsy, they can find the virus trapped in the lungs because they're generally trapped in immune cells in the tissues where your antiviral agents can't really get in and really kind of do what they're designed to do. The inflammation process and the Cascade storm, I'm sure everybody's, maybe if you're on any of these calls, that is 100% what everybody's seeing. These patients are they're dying and they're becoming critically ill and severely, more or less, their end organs are getting attacked from this Cascade storm. The inflammation Cascade storm. The pros and cons before using any kind of anti-inflammatory agents, or even there's even been some talk about doing some like some immunosuppressant drugs or even immunomodulatory drugs, kind of like we see with like heart transplantation, whether it be cyclosporine and some of those other things. The problem with that is that it's not a free lunch, because the downside of using those drugs, when you do get out, because those drugs have a long half-life. And the reality is that you can end up, because these patients are not going to come out of the hospital soon, you end up getting the downside of those drugs, which are ventilator acquired pneumonias, hospital acquired pneumonias, and then when you get into, you're talking the MRSAs and the really nasty infections that just hang out in hospitals. Those people end up succumbing to those. They don't die from COVID, but they'll end up succumbing to a post-COVID infection. And so there is not a free lunch when it comes to those antivirals. There's been some talk about using some interleukin-6 suppressors to try to stop the process. The problem with that is they don't know if it's upstream by interleukin-6 or it's downstream. And so really taking that out of the equation, it does the same thing. It's setting you up for a problem down the line. In the beginning, they're suggesting low dose steroids, but only until they're intubated. If you can get by with it and giving people low dose steroids to kind of suppress what's going on, but once they get too sick to where they have to intubated, they want to stop all the steroids. More or less, the disease process is going to progress, and the steroids aren't going to help you. That's what they found. Moving on to the coagulation, we talked about this briefly before. Coagulopathy is quite common in these patients. They've seen gangrene of the extremities from your microclot. It may be part of a DCD process. It may be just from an upregulation of an more or less of inflammation process, similar to what you see in trauma patients, your typical trauma patients on ECMO. We see that at Vandy with our trauma patients, that sometimes you have to do the range of the 50 to the 80 on the PTTs. But that we haven't. The only hospital I know that is using anything other than heparin is hospitals in Georgia, around the Atlanta area on ECMO. They've been using bivalirudin. That's the ones I've heard consistently. And then Dr. Schmidt talks about your ventilation strategy. He says that you have to. It's a completely different pathophysiology than your typical ARDS patients. You're seeing really good compliance, or he's seeing at least good compliance, lung compliance in these COVID patients. He just is suggesting low tidal volumes, low plateau pressures, and low PEEP. Definitely not high PEEP. He'd rather give people a higher FiO2 on the vent than higher PEEP. And that's kind of the results that they're suggesting, that they're getting some of the best results and getting people out off ECMO, off the ventilators, and full recovery with that strategy. And I guess there is really no magic bullet. It's more or less we're only seeing this as people are supportive care, providing weeks up to a month of supported care throughout the hospital. And the stratification between the patients that he's seeing, and really typically what we're seeing at Vanderbilt, is that your mild cases people are test positive. There's about 5% of them that are mild. They really don't even need to be in the hospital for the most part. They can come in, get checked out, and we're moving them on. There's some moderate to mild cases. We're seeing about 25 to 30% of those They may come in, get a little bit of supplemental oxygen, and then they're actually moved back out, back into their homes within a couple days. There's some moderate cases. We're looking at 30 to 40% of those. Symptoms are positive. Their CT, their chest X-ray, you can see that the signs of COVID, the typical signs. Those patients, they will, Vanderbilt has been starting those prior to intubation, a low dose steroids. But once they declare it intubated, we don't use the steroid anymore. And then the severe cases, we've seen about 20% of those. And what I want to say about 20%, if you end up being on a ventilator, we're considering you that's a critical case. So we're seeing about 20% of our total population going on a ventilator at Vanderbilt. Next slide. So this, I've kind of done a corresponding, I guess, outline of everybody that we've talked to over the last 4 weeks, and it's just kind of an international discussion. I do want to say Dr. Elaine Combs of Paris at Petit Hospital, he's been very instrumental in trying to not only consolidate the information, but he has one of the largest, I guess, populations that we can actually get some of this information to everybody. Paris, before this hit, Paris had I think it was 1,200 or 1,300 ICU beds in the greater Paris area, about a 30-mile radius. At one time, it peaked, I think, April 9th. They had 2,700 intubated patients in Paris and over 200 patients on ECMO. So they really have a large patient population that they can extrapolate some of the data, what's working, what's not, and he's been so generous to distribute all that information to people on these calls. Spoke with him as of last night. They currently at his hospital had 45 patients ECMO cannulated. 96, 97% of those, I think they had 2 VA patients on. The rest were VV, traditional neck groin cannulation. He's been proning 75% of his ECMO patients. He just finds that the proning actually gets a better result. So if they can be prone, what's really limited those is the number of beds that they have that are able to prone. Their mortality rate's about 15%. It is a little too certain to see how it's going to look, but he's hoping that there's at least a 50% mortality and survival of maybe up to 70%, but it's too early to call for him. He goes, we just have too many patients that are still in the spectrum of healthcare in their process to get a good number of what it's going to look like. As of last Friday, Japan, I take that back, 2 Fridays ago. So 10 days ago, Japan was getting worse. Their number of infected patients tripled in the last 2 weeks. So they have not peaked yet. They currently have about 75 patients on, and they're seeing the same type of mortality rates early. They do have some people that are on the back side of the curve as far as the more or less the transition of being infected, the inflammation storm, and now the recovery. But they still have a lot of patients that are being infected there. Dr. Mozami up of NYU, he responds to the call on every Friday as well. They're seeing right now, as of last night, there was 22 ECMO patients in NYU. That's currently. They've had a lot more than that, and they've decannulated a lot as well. Once again, everybody's just a little bit, I don't want to say pessimistic, but they just don't want to, they don't want to say that we've got this under control yet. They're really hesitant on declaring what kind of numbers and what kind of outcomes they're going to have. No one's really ready to speak forward about that. We haven't heard much from Boston. They're in and out on the call, but they've had over 100 patients intubated with COVID. And this was from, they weren't on the call yesterday, so this was from 10 days ago as well. And they figured that if they were going to get a surge, it was going to be last week. So they weren't on the call yesterday, and so I'm a little anxious, and I want to see what happened this last week in Boston. Next slide. So Chicago, although they've seen a lot of COVID patients, they haven't really reported too much of how many they got. This is at Rush, and so we didn't get it. Weren't on the call last night either, or yesterday morning. But once again, 2 weeks ago, they seem to have good experience, and it's funny from what we see at Nashville. We're not putting patients on ECMO. We're being able to manage them, with early intubation. But Chicago does have quite a few people that are on ECMO, according to the call 10 days ago. Philadelphia was on the call yesterday. They have about 35 patients on ECMO currently. I'm sorry, they put 35 patients on. They have had two deaths, but they think they're going to have a positive experience with with more or less the adjunctive therapy of ECMO on top of any other strategies they're doing. I'd like to come back to Philadelphia at the end of the talk. I didn't really want to put a slide together about it, but it has to do with the CytoSorb. It's a filter that we can talk about after the kind of offline as a discussion. And then we really haven't had any ECMO patients in Nashville per se. We've had 3, none at Vanderbilt, but we are intubating people early, and I would say we're tracheing people on about day 5 to 7. That's kind of the strategy that we're doing. It handles the secretions better. We can kind of deal with their heavy secretions. It's able to get them in and out. So we're trying to not let people turn into a multifaceted thing like with a pneumonia on top of the viral experience. UCF has said 0 patients on ECMO. They're pretty much like Nashville. They kind of mimic what we've got going on, or we mimic them on the calls. They really don't have much discussion about it, but they're on the calls weekly. Seattle has a long-term outcomes, and of all the people, they're kind of holding. I think they're getting ready to write a paper, come up with a published document of what they've done. And so if anybody, they haven't been the most transparent, and that's not to say that they're not adding to the conversation. It's just that their numbers. I don't know if they don't have a good feel on what the whole city's like, because it's multiple people within that city that are reporting on this call. And then the Cleveland Clinic, very similar to what Chicago has as far as how they respond. They've got positive ECMO experience down there. They've had a handful to a dozen on, but it's too early to call whether if they're going to get a fully recognized mortality to discharge. And next slide. And so the big takeaways as far as from an ECMO management strategy, kind of swinging from just total patient care to now that we've decided to put them on ECMO, what people are doing, they're putting large cannulas in. They're suggesting large cannulas. Once again, this is not personal experience for me, so I'm just regurgitating what the calls have been like. The PTTs 50 to 70, 1.5 times to 2 times the normal rate. They are seeing multiple oxygenator changeouts, but what they are not seeing is this huge SIRS effect, like you may see from time to time on normal patients, and they probably think it's because the upregulation of the inflammatory process is already at a peak with these patients. So if you're at 100%, or if you're a high number percentage-wise of what you've been upregulated on your inflammation, putting another oxygenator to re-expose you to another foreign surface, you can't get any higher, if you will. They're not seeing a big surge response with the oxygenator changeouts. And once again, the general vent strategy that I talked about, driving your pressures 10 to 12, peak no more than 10 to 15, and proning patients, and it especially works with patients greater with BMI of 30. And so that's really what I've got as far as slides. I wish, like I said, as far as a presenter standpoint, I wish I had more personal experience. But from a clinician and from a person, from Nashville, I'm glad I'm not seeing that. And so that's what I got, Joe.
Yeah, me too. I'm glad you're not seeing it too. But I think I think there's something in there that is latent, if you will. Why are you not seeing it? It sounds like you have patients. Yeah. You have patients. I don't know. I mean, you may not have as many. Okay, that may be true, but it doesn't sound like the number that you have is so different, where you have 5 versus somebody else having 500. It's not that large of a disproportion. So the question is it the vent strategy? Is it the early use of the vent plus the ventilatory strategy? Is it something to do with how they're being medically managed with various medications, whether it be antivirals or whether it be something else? You talked a little bit about the anti-rejection medications that were given, but there's consequences to that long term, which I think you discussed. But why? So Dr. Samir, Matt, I mean, maybe either one of you can start this off, but why are we seeing so many more patients over here? And UCSF is not a small place, and they have plenty of patients. Nashville's not a small place. Vanderbilt's not a small place. They have plenty of patients. Why are we seeing such a difference between place 1 and place 2?
I'll tell you, this is a public health issue. I mean, there's clusters or no clusters. I feel like there's parts of the country that have clusters, like New York. I mean, I think we are in the medium range. California has locked out. You know what I'm saying? So I think it's a public health issues. Why? I'm not sure why.
So are you saying it's socioeconomic? Is that what you mean by a public health issue?
Yeah.
Okay. So
I mean, you know that in New York, they're like people are overcrowded. There are a lot of people living together in the same apartment, and that increases the spread, obviously, for sure. That was the problem with New York. That's how Montefiore and Elmhurst got run over. They are in an area that I'm very familiar with that's highly overcrowded, that there's no chance of social distancing.
Well, I'll tell you that here, when we went through even just last year's influenza seasonal outbreak, we saw many more patients who needed to be put on ECMO. They had clear indication. And I just find this to be a fascinating question, because those patients that we had were also, it's the same socioeconomic strata here, whether it's this or that, where I'm in the same place. I'm not changing my location. And so I saw a lot during the H1N1 epidemic, saw a huge number. And now, really, I mean, with this, I've seen 2, the entire episode. And I don't know how much.
I have to tell you something. Now, I think you're pushing my buttons, so I'm going to have to be a bad boy right now. Okay, I have to tell you, and this is not to say that we are the best. There's nothing. Texas is very aggressive. The Med Center has more than 2, Joe. You know that.
Yes. I know they do, but
we have a lot. We have people that decannulated and gone home.
But they're not inundated. They have more. I don't disagree, but they're not inundated. I mean, they're not.
No, but nobody thought we were going to be inundated with ECMO. Nobody thought there was going to be an inundation with ECMO. To be honest with you, the inundation was all about the ventilator. It was never thought about to be the inundation with ECMO. Because again, it's still a precious resource, and you triage who you're putting on ECMO. So I think it is the ECMO experience is as we thought it was going to be. I don't think we're underestimating what happened or overestimating. I think whatever patients on ECMO in the 3 hospitals, in the 3 systems, the Med Center, they are the ones we thought they're going to be. I don't think there's under or overestimation. I think, I don't think it is any. I think we have just low threshold putting people on ECMO. And that, I agree with 100%. Other people don't do that, and that's fine. I mean, and it's related. We have been very progressive when it comes to MCS, and whether that's right or wrong, it does not matter. I mean, that I will have to say.
Well, Matt,
I would agree with him. I think it is. It's based on your threshold and your comfortability. I mean, the other thing that, to your point, when you talked about socioeconomic, Joe, I don't know if it's if I want to use that term, but what I have thought about, Nashville does not have a public transportation system other than buses, and with this being as contagious as it was, and to the doctor's point, people were on top of each other in New York, in Chicago, in Paris, where public transportation is a huge thing. Italy, Japan, all these places that you're seeing these large outbreaks. And I'm not saying that any outbreak isn't significant, but I don't think we've seen the end of it in Nashville. I think we're going to slowly. So we had the most patients we've had was 32 in the hospital at one time, but we've had no less than 25 ever. And so as people come in and people get discharged, people come in, people get discharged. Our line has been flat when it comes to the amount of patients we've seen in the hospital. But and the same way on the vent patients, we've had as many as 8 ventilated at one time, and as low as 4, and that's been for weeks now. And and it's people are either transitioning out of the hospital, surviving. We have had some deaths. We haven't had a lot of deaths, but to the doctor's point, I think we decided at the very beginning, because we only had, we only had to have the capacity of having 17 ECMO patients at one given time. And so I think we were going to try to hold back on that resource, only because we felt as though if we pulled the trigger early on that, we may inundate us with where we're going to have to make a decision on, when you get down to your last 2 ECMO circuits, are you going to go, well, who needs to really be put on? And because it is a known valuable commodity. It is not. You can't make more ECMO circuits overnight. I know you can't make ventilators overnight, but ventilators are a lot easier to come by than ECMO circuits. Let's just put it that way.
I agree. Well, I agree with you 100% on that. I really liked, Matt, what you said about collaboration. I wish, and I understand the competitiveness. I like the way you had said it, and that how this has sort of washed away that inherent secrecy, and it's very open and collaborative. I think we need to be more like that in a lot of different things. And when I say socioeconomic, look, I mean, I think I believe it's commonly understood that people that are in the lower economic strata tend to have poorer diets. They eat things that are unhealthy because they're easy, convenient, inexpensive, fast food, McDonald's, Burger King, and so forth. Their obesity rate is much higher. Dr. Samir had a slide where it showed that patients that succumb to COVID are very, very high rate of mortality when you add obesity into it, much more so than if you have any of the other known comorbid conditions that increase mortality with it. Obesity was number 1, had the highest degree. And I think that unfortunately that's something we see not infrequently in that group of people. And I think that Nashville is a more, affluent, San Francisco is a more affluent, Houston may be a more affluent society than some of those places, not every place clearly, but there's a larger percentage of people in New York, Chicago, Detroit that are not as affluent, that fall more into that category. So their percentage, I think, is a little bit higher, and just the sheer volume of those people is a little bit higher. And that's an opinion. I'm not 100% sure, but that's what I would hypothesize. Earlier treatment, they tend to not seek health care as fast. And so I think that, you're treating people earlier. I think that's going to make a big difference. I am confused about something, and I hope you can clarify it, because I do want to hear about your discussion on the adsorption filter, CytoSorb, because I'm very interested in this. But you had said there were multiple oxygenator changeouts. Now, notwithstanding, your point, I think, was that they're not seeing the cytokine bump up that you see when you change an oxygenator and add an artificial circuit into the mix, because they're already peaked, as you said, with their cytokine storm or inflammatory processors. But why were the multiple oxygenator changeouts? That's the part that I want to know.
Well, in the beginning, what they were seeing, and this is from the Paris experience, is that they were using their normal, more like coagulation, just normal coagulation. Until they realized that these people are a little more coagulopathic, then they had to keep bumping it up. But what they did find, that they were so concerned, they were like, this is going to put people over the edge, changing oxygenators out. They didn't see that result. It was what you would typically see on an oxygenator change out. So they're not changing oxygenators, and maybe I misspoke on that, or wasn't really clear in the beginning before they realized that they had to use a higher PTT. They were going through oxygenators a lot quicker.
Yeah, that's a good point. I just wonder though whether or not we're misinterpreting clot for perhaps because of this inflammatory storm, this cytokine storm, that we're not clogging versus clotting the oxygenator. And that's why you're seeing such decreased efficiency. The question that I have for you is, do you routinely measure intra-oxygenator blood volume? Do you use that device that's made, I think it's made by Transonic, and it's called the ECMO, and you can measure intra-oxygenator blood volume with a 20 cc injection of saline? Are you familiar with it? Do you use it? Do you think you should use it to differentiate between clot occupying your oxygenator versus, unless you see it, of course, versus it being clogged, the pores, by inflammatory mediators that may be adhesing to the oxygenator fiber material?
Sure. If I am briefly familiar with that. I think we're going to have someone come in the next month or so. As soon as we can have open visitors. We had a plan to get some people in there in March, and with this happening, we weren't able to get that device in there as quickly as we'd liked. But if I know the device we're speaking about, it's where you inject it, and it's almost like a fixed law, almost like the old thermodilution ones, where you could figure out exactly what your based on your flow rates, what your volume is in the oxygenator. Is that correct, Joe?
That is correct. Yes, and you should have called me. I'd have brought mine and come done it with you. But it measures intravascular blood volume as well. I mean, intra-oxygenator blood volume. So you usually get a baseline. But if you know what if the data sheet tells you what the specs on the oxygenator, if it holds 210 cc's and there's 210 cc's of volume there, then you really don't need to have done a baseline. But it's good to do a baseline if you can, and then you can measure it serially, every day or whatever, and see if you're starting to see a reduction, which would theoretically be it's being obstructed by, it's being occupied, the space is being occupied by clot. And it's really interesting. It's some very interesting data with it. But on VV ECMO, it also measures at the same time with the same injection recirculation. So it'll give you a percentage of recirculation and an effective ECMO flow, so you can do both. So VV ECMO does both, but on VA ECMO, it's only going to measure, obviously there's no recirculation, it's going to measure intra-oxygenator blood volume. It's a very useful tool. I highly recommend it for anyone. I kind of wish that I'd been able to come up too, because no one has talked about, and Dr. Samir, you may have some thoughts about this, but no one has really discussed the use of microcirculatory visualization in these patients in its determination of treatment modality benefit or in predicting survival. What do you think about that?
Because people are looking at it as a respiratory shock stage, not a hemodynamic shock stage.
Mm-hmm.
I mean, you're not really using hemodynamic support for those patients.
Mm-hmm. So you don't really see any use for it?
No, I don't think so at this point.
Mm-hmm. Okay. And then I guess too, let me see, there was that. What else did I need to ask? There was something else I wanted to ask, and of course, I'm having fleeting memory issues, okay? But it'll be interesting to see how this all plays out. Let me let you two sort of add some, I know what it was. Matt, you said something very very dear to my heart, and I really want to hear about it now, and that is on the CytoSor, because I have some information on that too, And I want to know what your thoughts are on that and why you feel the way you do. Dr. Samir, I want to get your thoughts on that, and then I can add some of my thoughts at the end.
The only two I've got one on the interviews that we've been having. Paris has used it a handful of times on their patients. They're not using it except for on the once they get to a full-blown septic state. The cost in U.S. it's now approved for compassionate use, emergent use, whatever the verbiage is. It was not an FDA approved thing. It may still not be except for compassionate use. They're costing U.S. dollars about $1,200 a piece. Linda Mongero had a great talk on that a couple weeks ago on a conference call. What they are doing in Paris and what I've seen or I've heard what they've done here is they're using it in line, kind of like a CRRT for 12 to 24 hours at a time. It does reduce all the cytokine, all the interleukins, but you have to do serial tests on them. And then what they're seeing, unfortunately, is after 4 to 7 days, you get the if they're still on ECMO, you get the return of all that. And so it's almost like a re-up of the same things. And so every 4 to 7 days, they're having to put another one of these in to more or less, if you will, filter out all that again.
And you're saying it's $1,200?
What I've been told, it's $1,200 per filter.
And you use a filter for 4 to 7 days?
No, use the filter for 12 to 24 hours.
12 to 24 hours, okay. And
it works. What I've been told is within 4 to 7 days, if you're monitoring the serial testing of the cytokines, and you'll see it 4 to 7 days, it'll start ramping back up. And so I have very limited experience. The Paris group, they're only doing it as if you will, a Hail Mary on the septic patients, because Dr. Combs, he's looked at the papers on that, and he says, I'll quote him on this. He says, the evidence is very weak at best. These patients, because I think what happens is that you can filter it out, but it just comes back. That's what we know about it.
Yeah, that's interesting. I'm really interested to know more about. I've always thought that it made sense. Why it's reemerging, of course, I don't know how much of that is due to it not being, to the issue not being necessarily addressed properly. Clearing it makes sense, but you have to have a reason for it to then, reemerge, have a second wave, if you will, of cytokine storm, because that's generally going to be due to some antigen that's causing that to happen that has not yet been cleared. So it doesn't really it makes more sense to me to do it than not to do it, but based on what you're saying, I can understand where that would be. That's an opinion of mine, and again, the evidence may not be there, which is a different issue. There is another device, just so you know, that is FDA approved under an emergency basis, though, so I will make that point, for COVID-19 patients, and it's made by Baxter. And if you do CRRT, which I'm assuming you do, and I don't know whether you use the Prismaflex machine or what machine you use, but they have the Prismaflex and the Prismax, but they're the only company right now that does CRRT that has this available, and it's called the Oxiris, Oxiris. It's been used very successfully in Europe, and now it is FDA approved here for use, and it's basically a CRRT filter. It's the same exact filter set, but it has a special heparin type bonding to it. Of course, that'd be a problem if you had hits, and it's obviously contraindicated if you do have hits, but it's an adsorption filter, a little similar to the CytoSorb, but this is just a more simplified version perhaps, and it can also perform CVVH, I think, simultaneously. So you have double benefit, and it is proven as a clearer of the evil humors, if you will, the interleukins, the complement, the TNF alpha, all that stuff that we want to get rid of. So that's available on the market also, and it's by Baxter. But it's called it's the Oxiris, Oxiris. I don't know if I'm saying it right, but it is FDA approved for emergency use or emergency approval authorization for blood purification, specifically for COVID-19 patients. So not patients who are septic for some other reason, but for COVID-19 patients. So I wanted to pass that information on to y'all. Dr. Samir, what's your thoughts on all of that?
I think right now, to be honest with you, in my opinion, the only thing that you have to triage your resources. So if you're on ECMO, I think continuous CRT is the way to go at this current time.
Well, I finally, I have drugged you kicking and screaming.
But all that, we discussed this privately, why you cannot put everybody on CRT. We discussed this.
Yes.
You know we did.
Yes. But
Okay.
it drives me crazy when people say, oh, well, you're going to be adding another machine and you're increasing risk. And Matt, I want your opinion about this too. And I'm like, the patient has got 8 IMED pumps, it has a rapid transfuser, and is on ECMO. And you think adding a CRRT machine is over the top? So that's, I'm like, I think, Matt, my view is every patient on
resources.
Yeah,
resources.
my view, Matt. Yeah, exactly. My view is that every patient who is on ECMO should be on CVVH. I think it's just really good for maintaining acid-base balance, electrolyte, basically homeostasis, and not cheesy CVVH, not just continuous dialysis, but actually convective clearance. Because we do need to remove plasma-free hemoglobin. We do need to remove some of the larger molecules that you just can't do with straight diffusive clearance. So what's your view in Nashville? What do you guys do?
We're using CRT quite regularly. I mean, as we all know, acute kidney injury is one of the first things that happen. Whether it's due to blood pressure, whether it's due to just sickness, but most of our ECMO patients do end up on some sort of CRT. I would say about 75% of them,
Mm-hmm.
Where I find there's a little bit of we'll say mixed opinions within our institution is whether that you hook it up to the actual ECMO circuit or you use a traditional VAS cath in the patient. We have a different model to where the perfusionist is in-house 24/7 hovering over all the patients, and we've got bedside nurses that are and nurse practitioners on the floors that are taking care of these patients, but they are not the ECMO machine experts.
Mm-hmm.
And so anytime you introduce another machine into the circuit to where you have a chance to entrain air, I get a little nervous. So I'd much rather, and you can entrain air just as well, through a VAS cath if it's positioned, and you leave it open.
Sure.
But anytime there's a CRT circuit on my ECMO circuit, I always find it's a little more, it makes me a little more nervous. I'll just put it that way.
Me too. I can't dispute that. But of course, if it's a secondary, consideration, and you don't have, any other place to stick anything.
Yeah, you have to do what you have to do.
And you don't want to stick the patient for fear that you're going to hit something you didn't mean to hit, even using ultrasound. I've seen it happen.
Sure.
And you don't want to have, a vessel that's been an artery that's been perfed. I don't know. It is a judgment decision, certainly. And I think we have the luxury of we're at the bedside, 24/7. We're only dealing with usually one at a time at any one hospital. So I think we have that luxury, whereas I think when you're dealing with multiple patients and codes going on here, you got to get to a different floor, and depending on other people like that, it would probably make me a little nervous too. I probably would feel differently than I do at this point. But I'm a big believer in it. I think it's a an understood and underutilized and a frequently improperly utilized tool that I think should be used more often in more of the right circumstances. Because I do think it has a place, but it's a very specific it's a specific place that it belongs. And I think that I just find that its application is not utilized to its full potential, and frequently it's used when it really shouldn't be used. And then you have, marginal or at best, very, inconsistent outcomes, and it makes the whole therapy not look that good. But that's just my opinion.
I will comment one other thing that it kind of made me think about this. When Dr. Samir said that that ECMO is a finite resource and how we pull the trigger, and I can't remember who was on the call. It was one of the U.S. places. I almost want to say it may have been NYU, or it could have been Philadelphia, that said that was going to be one of this was 3 weeks ago, that was one of their contraindications. If the patient had to be on CRRT, they could not be on ECMO as well. And now they've come back. Now they've come back since then to change that. What? But in the very beginning, I think to more or less to Dr. Samir's point about pulling the resources and knowing it's what resources that they were gonna, they didn't want to throw what they felt was good resources after bad, if you will. And so they've retracted that, but that was a big discussion 3 weeks ago, early on.
Yeah, that's very interesting, and I think that comes from, Matt, I'm really glad you said that, because I think that comes from the mentality, and Dr. Samir, I do need you to elaborate on this. It comes from the mentality that the patients are only put on CRRT when there's no other option. They're so hemodynamically unstable you can't dialyze them. You're in a futile, almost futile situation, and we're just going to throw CRRT at them. But my way of thinking about this is we see much better results. You're seeing it with early intubation, not waiting, not letting the patient suffer with relative hypoxemia and struggling to breathe. With various different other mechanisms, BiPAP or just high flow oxygen. So venting them early, tracheing them early, putting them on ECMO early, and I believe putting patients on CRRT early, all lead to, at the end of the day, better outcomes. But I understand, and again, I know Dr. Samir will point this out, and it's true. You increase your exposure to criticism that you put those patients, you tube them too soon, vented them too soon, trached them too soon, put them on ECMO too soon, use CRRT too soon. Those patients could have done fine without any of that. That's what the exposure risk is that people will criticize you about. But when you look at every data set that I've ever looked at for my entire career has always showed much better outcomes with earlier intervention than late intervention.
That's true. I mean, you see much higher mortality and morbidity with late intervention. You intervene late, you're past the point already. You should not intervene, you should leave things alone.
Yes, I agree with you, but we don't. We use, I've seen it before. Matt, I don't know if you've seen it maybe you might not see it at Vanderbilt, and of course, Dr. Samir, you're not going to see it down at Texas Medical Center, but I can assure you I've seen it in the community-based hospitals where I have seen CRRT and ECMO both used almost as palliative care, and it just makes no sense to me whatsoever, but I've seen it happen.
I don't claim to comment on and know about CRRT, but I think historically, because ECMO had a stigma, kind of a stigmata that it was, we're talking all the way back in the data back in the early 80s.
LVADs.
Of that, ECMO was pretty much a death sentence. Well, the reality is because I think back then the technology was so bad, and as far as the the oxygenators, the coatings, everything that technology has brought to us to into 2020, when we were trying to use the same physiologic and physics principles with rudimentary devices, I think that was too much to overcome, even in the patients that were survivable.
Mm-hmm.
Absolutely.
And I think as we've gotten this farther with technology, that stigmata has come with us, is that ECMO is still at best 50-50. That's the mentality. And really, to be quite honest, ECMO, when utilized appropriately, is much higher than 50-50.
Absolutely. For VV, it could be as high as 70%
Sure.
survival. For VA,
Sure,
it could be as high as, depending on if it's a cardio, like you gave that talk recently on the experience in Paris, where you drop dead in the grocery store and you're having and you're under CPR. Your chances of surviving was in the single digits. And with their ECMO program, they've gotten it as high as, what did you say, 18 to 22%, or something on that range?
It's over 20% now.
That's huge.
And you say that's it's still 20%. It's much better. It's 3 times what your single digit. It is.
Yeah, you can't argue the point. As far as I'm concerned. Okay, so let's do a final thought if we could. So I'm going to start off with the most esteemed of us all, Dr. Samir, and ask you to sort of impart to our audience where you think all of this is ultimately going to go, specifically regarding COVID-19 and whether we'll see a resurgence in the winter, what you think's going to happen, treatment-wise, vaccination-wise, the whole gamut.
Okay, so I will have to say my little political statement, which political and clinical. I think right now with pushing to open back very quickly, we're going to see a resurgence earlier than the winter. And the resurgence, I feel, is going to be worse than the initial wave because we're getting relaxed. Things are doing okay. People are going home where they're not dying. We're seeing much with a positive outcome. Now we're getting a little too comfortable. The only thing, Matt, I'll tell you, I disagree with you with one thing. And if you or Joe come under my care, I will start you an antiviral right away. I'm a big believer in antiviral.
Okay.
And I'll tell you, and I've been a big believer in the beginning. But the studies have been showing that, and I don't have any stock in remdesivir, that remdesivir you start early, the patients are going home much quicker. And I agree with the superimposed pneumonia. So you have to go back to the old-fashioned way. Start remdesivir and start vanc and zosyn.
Okay.
Unfortunately, I know somebody I work with that got the superimposed pneumonia. The superimposed pneumonia was worse than the situation itself.
Mm-hmm.
So you really have to worry about the superimposed pneumonia early.
Mm-hmm.
So I do feel the antiviral is going to have a huge role. Vaccine is coming, but it's going to take a while. That we have to be very careful with, because that's something you don't want to start inoculating the whole population unless with something that could be harmful or not useful.
Mm-hmm.
I'll tell you, remdesivir, any antiviral, but I've seen remdesivir because we're part of a study. I have told the study coordinator, I got hospitalized with COVID-19, I want to be on remdesivir. Mm-hmm. So this was like a preemptive strike for me in case I got sick.
But you want it early, right?
Yeah, I want it early, yes, absolutely.
The
company
mm-hmm.
has expanded its criteria. There was a limitation from the FDA. The FDA loosened up things, and Gilead loosened up things. So the expansion of the criteria right now. But you do have to go apply for compassionate care, like Matt said. You have to send an application. It's not automatic.
See, I think what a lot of people don't understand, Dr. Samir, is that the whole idea of the antivirals, from what I understand, and of course you could correct me if I'm wrong, but you need to control the viral load to avoid the subsequent cytokine storm that comes from the viral load being out of control. Do you feel that's correct?
It's kind of, you're trying to block the viral load from getting into the cell. That's basically the concept. You're blocking the virus from getting into the cell.
Right. Okay. So rendering it inert.
Exactly, and that's the whole premise of the situation.
Okay.
So I believe in that. So I think I ask everybody, if you don't care about yourself, I'm okay with you not caring about yourself. But you need to care about Joe, you need to care about Matt. You cannot be, if you exposing yourself and then expect Joe and Matt to take care of you. And I read that something was on the news, really remind me back in the day of Tiananmen Square. This doctor stood in front of the truck in Austin because they were demonstrating for going back to work very early and opening the country. So this doctor reminded me back of Tiananmen Square that they felt that they're being killed by patients exposing themselves and then showing up to the hospital. So I'll tell you, I think we need to be very conscious of this situation. And I hope all of you stay safe, please.
Very good point, and thank you. That was excellent. Matt, what are your thoughts?
I honestly think it's the same. I'm going to agree with Dr. Samir, but I think the resurgence is going to be, if we're not careful, and you know, people, we're going to have to be careful for quite some time. But you know, these plans that have been rolled out, you know, from from the White House, and then just I guess it was Wednesday, our governor here in Tennessee rolled out a phase on what we're going to do throughout the state, but then left the 4 biggest counties in Tennessee, the mayors, to roll out. So Nashville's just rolled out a plan that every 14 days, after 14 days of a flat slope on the infection number, that they'll graduate to a different phase. And then in the event, you know, there's an increase in the infection rate, it can either take a step back, or it will maintain on that particular phase, and has to do with businesses open, what kind of capacities restaurants can have, whether it's 50%, 75. Bars are not open until the very last phase, and then even at the last phase, they're only at 50% capacity seating only. So there's no standing, there's no interaction in the bars, and you know. From a Nashville standpoint, you know, Broadway's a big thing. I mean, we're second only to Las Vegas when it comes to the strip of what happens down there on honky tonks. But the reality is I honestly think we can't wait for a vaccine. But I do think that if you look at the curve and the exposure, there, to your point, the obese, the elderly, and the high risk are really going to continue to have to be very vigilant, and we need to be very vigilant of them as well. I mean, I just think I think it's a dual-edged, even if it's that we have to do grocery runs for the elderly or the people that are immune suppressed, they don't need to be out, and that's my opinion.
Agreed, and we don't need to go see them other
Correct.
than to drop something off that's been disinfected and let them open the door and take it in and stay far enough away. I think you're right. We need to protect the most vulnerable in our society, but we do still, I think, have to get our society open. So I'm going to close my remarks with most important is thanking both of you for taking time out of your Saturday, your personal time, out of your lives to do this, because it's so appreciated by me and by everyone else that will watch this video, watching it now, and will watch it later. That's number one and most important. Second is, Matt, do you remember the name of the restaurant that we went to when Stephanie and I were there with you and your wife?
The Cork and the Cow.
The Cork and the Cow? That's right. And anyway, Dr. Samir owes me dinner. And so he's going to be taking me to Nashville to go to the Cork and the Cow, and I'd like to invite you and your wonderful wife to also come. So it'll be Dr. Samir, his lovely wife, Vicky, and myself, my lovely wife, and you and your wife, and we're going to go to the Cork and the Cow and have a wonderful dinner on Dr. Samir.
Because we need to invite Magic and David too.
Yes, Magic and David, of course.
You forgot about Magic and David. I'm here for them.
Well, you know what we're going to do? We're going to go on location, because David loves to go on location, and we'll do a program from the Cork and the Cow. I'll have him bring the live stream box and all of the cameras and everything, because that's something that David truly loves to do. I can assure you of that.
Are you gonna fly us in your little jet over there?
Well, if you close your eyes and pretend you hear jet noise, yes, it's a jet, but it's just got a big fan in the front, and it just spins around and pulls the airplane forward. So yes, I will fly us in that airplane. if you so desire. No problem at all.
Please, let's make sure we land in Tennessee. We don't land up in Missouri, or we land up in Portland, or we don't land up in New York.
We're gonna do our best. I have a really good GPS and autopilot, so thank God the airplane flies itself. I don't have to do a whole heck of a lot. But with that said, I just want to thank everybody. And as you know, I get continued questions. If anybody wants to reach out to Matt and Dr. Samir, please just send me those questions. I'll forward them on to them, and they can answer the questions as you see fit, and we'll go from there. So again, thank you again for a wonderful experience, informative and highly professional, and we just appreciate you. That's all I can say. I've said it about 50 times, but I can't say it enough. Have a great rest of your Saturday, and stay safe, and we'll see you all on Monday when we start the Corona 30.
Thank you. Stay safe too.
Bye.